So next is the alcohol-related dementia, which frequency is not really known. It's a form of cognitive dysfunction caused by long-term excessive consumption of alcohol, resulting in brain damage. Usually in the 60s, after at least 10 years of regular alcohol consumption. It's a variable combination of frontal dementia, Wernicke's encephalopathy, Korsakoff psychosis with a lot of confabulations, peripheral neuropathy, and a cerebellar ataxia. The etiology is simple. Alcohol causes direct damage to the neurons and glial tissue, and a lot of malnutrition is also involved. The treatment is also simple: abstinence from alcohol and improve the nutritional status. So next is the HIV-associated neurocognitive disorder, or HAND, which is a syndrome of progressive deterioration of memory, cognition, behavior, and motor function in HIV-positive individuals. Usually occurs in the later stage of the disease. So the presentation has been classified into 6 different stages, whereas stage 0 patients are normal mentally and motor functions are absolutely fine. And then stage 0.5, you see mild cognitive impairment, but the gait remains normal. Stage 1, the IADLs can be affected, but the gait remains normal. Stage 2, 3, and 4, the gait and cognition starts to decline until the patient becomes nearly vegetative and absolutely mute. So this syndrome typically occurs years after HIV infection. It's associated with low CD4 count and a high viral load. Incidence has declined a lot in developed countries due to the availability and access to high quality antiretroactive therapy. The pathology is primarily caused by the virus itself and its invasion of neurons, but it can also be affected by opportunistic infections, CNS lymphomas, toxic effects of medication, and malnutrition. The areas most affected are the hippocampus, the frontostriatal connections, and the putamen. It's unclear why it picks these particular areas, and there is a cerebral brain volume loss overall. So for the diagnosis of HAND, you need a marked acquired impairment of at least 2 of the 6 known cognitive domains. The impairment should interfere with day-to-day functioning. It must present for at least 1 month and do not meet the criteria for delirium. There shouldn't be an evidence for another pre-existing cause that may explain the dementia. And this routinely requires a careful history, neuro exam, brain scans, and a lumbar puncture. The amount of the virus in the brain does not correlate well with the degree of HAND, but we know the viral load in the body and the low CD4 count does correlate. The prognosis and treatment are poor if untreated, basically fatal, and the highly active antiretroviral therapy can prevent, delay, or improve the symptoms of the syndrome. Next on the list is the prion disease, or the transmissible spongiform encephalopathy, which is a group of rare, rapidly progressive, usually fatal conditions. There are several types, with the most common one is the Creutzfeldt-Jakob disease. It usually presents with personality changes, depression, sometimes psychosis. It also presents with ataxia, myoclonus, pyramidal spasticity, and Parkinsonism, and then disturbances in awareness. So it begins with a lot of insomnia, confusion, mutism, coma, and then death. So most cases of sporadic Creutzfeldt-Jakob disease occur between the ages of 45 and 75, around 1 new case per million per year, so it's quite rare. The etiology depends on the type. It could be sporadic due to mutations in the PRNP gene, which normally regulates the copper transportation within the cell. When it's mutated, it produces toxic proteins that starts destroying neurons. The familiar forms are caused by inherited mutations, and there is a transmitted form due to the exposure of prion contaminated tissue, either through ingestion or iatrogenic. The pathology is basically neuronal cell death with spongiform changes, and you can see the accumulation of the amyloid plaques and the prion protein under the microscope. So the diagnosis of prion disease, usually upon clinical suspicion, you should seek CSF analysis for the quick induced conversion, which is the gold standard for diagnosis. Other supportive tests include the detection of the 1433 protein and a high tau protein content. The imaging, including the MRI, DWI, will show hyperintensity in the cortex, striatum, and the putamen. And the EEG will show the periodic synchronous biphasic or triphasic sharp wave complexes. The prognosis is pretty poor. Patient usually dies within 6 to 12 months from the onset of symptoms, and the treatment is mostly palliative care. Next is the new addition to the list, chronic traumatic encephalopathy or CTEs, which is a tauopathy caused by repeated head trauma. Usually presents around 10 years after the repetitive TBIs. Stage 1 usually starts with a confusion, dizziness, headaches, sometimes some mood changes. Stage 2 shows mild memory loss, executive dysfunction, impulsivity, and poor judgment, so mostly frontal symptoms, and it can present with some paranoia. Stages 3 and 4, the disease becomes more advanced with dementia, Parkinsonism, deafness, vertigo, and the depression may progress to become severe with suicidal ideation. The rates of the disease have been found to be around 30% among those who suffer from repeat multiple head injuries, and was found in some degree for 99% of tested NFL players, also hockey players and military personnel, especially those who served in mountain areas. So it's mostly caused by contact sports, but it can also be caused by combat sports. The pathology is usually characterized by deep parenchymal phosphorylated tau aggregations around small blood vessels. These are usually pathognomonic, and then it spreads to other brain regions. The diagnosis, nothing really is available except by brain autopsy. Treatment is nothing is available, and it's mostly symptomatic care. So that brings us to the end of our exhaustive list of causes. However, there is one more cause that I'd like to talk about, which to me is last but not least. That is the reversible causes of cognitive impairment. And I can't stress enough how important excluding these causes are, because I've seen in clinical practice multiple patients, older adults, who present with cognitive impairment that is quite profound, that you may think this is straightforward Alzheimer's disease. And when you look for reversible causes, you find at least 3 or 4 of them. And upon treating those causes, the cognitive impairment almost resolves. So here's a simple list for the reversible causes of cognitive impairment that may affect older adults. The first one is delirium, because the recovery from delirium in older adults may be protracted and prolonged, which may mimic dementia. Depression is another big one, because it presents a lot with cognitive impairment, especially in older adults, something that we call pseudodementia. You should look at the list of their medication, any substances they are using, including herbal compounds. Blood work should show any metabolic derangement, hypothyroidism, or vitamin deficiencies. Other miscellaneous causes of cognitive impairment may include epilepsy, anemia, sleep disorders including sleep apnea, and CNS infections or tumors. So now that we've learned the types of neurocognitive disorders, including reversible causes of cognitive impairment, how should we approach a patient coming to the clinic presenting with a cognitive concern?